It's my honor to introduce Dr. Phoenix Matthews. Dr. Matthews is a professor and associate dean for equity and inclusion in the College of Nursing at the University of Illinois at Chicago. They have more than 25 years of experience in examining determinants of cancer-related health inequities among racial and ethnic minorities and other underserved populations. Their recent research focuses on the use of community-based health promotion interventions to reduce cancer risk factors with a particular focus on smoking cessation. Dr. Matthews has served as the PI of 6 federally funded grants and co-investigator for several others. And currently, Dr. Matthews is an MPI on an NHLBI grant to conduct a population-based smoking cessation intervention for low-income smokers receiving care at federally qualified health care centers. In addition, Dr. Matthews also serves as the Helen and Grace Diversity Scholar for the College of Nursing at UIC and is the co-founder of the Chicago Restroom Access Project, an important public health advocacy group aimed at increasing access to public accommodations for transgender and other gender minority individuals. I'm a longtime admirer of Dr. Matthews' work and continue to learn from their scholarship. Please join me in welcoming Dr. Matthews as they talk about their current work.
Good afternoon from the Third Coast, affectionately known as Chicago. So I'd like to, again, thank the organizers of this panel. It's been a distinct honor to participate along with the other presenters who have done an amazing job thus far. As mentioned, my work is primarily related to tobacco prevention and control, but I'm going to talk with you today about a slightly different area of work. We're interested in looking at some of the beyond individual levels indicators of cancer inequalities and to describe the literature on social determinants of health and cancer inequalities, highlight what is known about the research related to social determinants and sexual and gender minority communities. As we've heard from Dr. Bowen, there's a lot of work that describes the disparities, but much less work that looks at mechanisms, drivers of disparities, and even less that relates to intervention. So I'll be talking to you about what is known about some of the social determinants in health and as it relates to sexual and gender minority populations, and then make some recommendations for future work. So what we have is a positive area is that for the past 30 years, we've seen substantial increases in cancer survivorship across the board. We know that a lot of the increases in cancer improvements in cancer outcomes are associated with improvements in diagnosis, treatments, and then changes in behavioral risk factors such as smoking. And so consequently, we're seeing an enormous increase in the number of cancer survivors across the country. But despite the amount of progress that has made, not all population groups are benefiting equally from some of the advancements that we're seeing. And that we know that there are a number of disparity populations as it relates to cancer incidence and mortality. Socioeconomic status, individuals who are living below poverty or low SAS, sex differences, differences by race, ethnicity, geographical location, and disability status. Here are some examples of types of cancer disparities that we see currently in the literature and some of the socio-demographic characteristics that are associated with those. So we see, for example, that African-American women are twice as likely as white women to be diagnosed with triple negative breast cancer, which have not made as much advancements in treatments in these areas and are much more likely to die, have a greater likelihood of dying from breast cancer than white women. And you see similar types of disparities on kidney cancer, liver, prostate, cervical, and multiple myeloma, just to add a few examples. So, but despite LGBT population being officially designated as a health disparity group, the National Cancer Institutes and other institutes have all acknowledged that there is a substantial gap in our knowledge in cancer-related research based on gender and sexual minority status. The data, at this point, we don't have precise data on cancer rates among sexual and gender minorities across all cancer diagnoses. Primary reasons for that is the lack of systematic collection of sexual orientation and gender identity in healthcare systems, as well as SEER, the cancer databases, which prohibits us from doing national analyses on cancer rates and cancer deaths. But we do know that sexual minority status contributes to excess risks for breast cancer, anal cancers, lung cancers, and cancers associated with HIV and AIDS. The causes of identified disparities and the cancers that have been identified are complex, and they're likely related to a number of factors that are known to influence cancers in the general population, as well as some LGBT-specific risk factors. So risk factors in the general population relate to behavioral risk factors, smoking, drinking, obesity, reproductive risk factors such as for lesbian women, nulliparity, less likelihood of having children, or older age at first birth, and lower rates of hormonal contraceptive uses. Historically, lower rates of cancer screening among sexual minority women, although in the recent decades, some of those disparities seem to be closing, the gaps seem to be closing. And then poor access to culturally competent healthcare, either due to lack of insurance coverage or bias in healthcare systems from providers, as well as lack of information about LGBT populations. So today, we do know that the majority of research on sexual and gender minority population as it relates to cancer has been focused on identifying individual level risk factors, so descriptive studies. But less is known about what has been a focal point of research for the last decade across cancer prevention and control more generally, relates to social and environmental factors, okay? So otherwise known as looking at social determinants of health. So looking beyond the individual to have a better understanding of the social determinants of health and how those factors, which are thought to be structural determinants and conditions in which people are born, grow, live, and work, and how these contribute to health outcomes. This graphic, I think, points to the importance and the significance of looking beyond individual factors to considering social determinants of health. If we're looking at this chart, we see the individual level behaviors, such as health risk behaviors, smoking, diet, alcohol use, contributes to health inequalities in general, and cancer inequalities more specifically. But it only accounts for 30% of the overall variance, or the overall types of risks that contribute to cancer disparities. Larger percentage of factors are related to things that are beyond the level of the individual, such as socioeconomic factors, the physical environment, and the healthcare system itself. So in the Healthy People 2020, organized the social determinants of health around these 5 key domains that we'll talk more about in turn. Economics, stability, education, neighborhood and physical environment, the community and social context, and the healthcare system itself. So let's first start with economic stability. Socioeconomic status or income level has been shown to be a strong driver of all-cause morbidity and mortality for the last 150 years. We know that in both individual level income and neighborhood level income or economic factors contributes very strongly to cancer disparities, especially in racial and ethnic minority populations, who are much more likely to live in segregated, impoverished communities. When we look at sexual and gender minority communities as it relates to economic security or insecurity, as the case may be, we see that LGBT adults are much more likely to live below the poverty line compared to heterosexual adults, that there's a relatively high reliance on federal food stamps and the experiences of food insecurity, again, even higher percentages for racial and ethnic minority groups. When we think about transgender populations, we see much more elevated rates of poverty and associated homelessness with that. So the factors that are associated with these disparities in economic stability and well-being haven't been thoroughly analyzed and aren't known. And this will be a theme throughout my discussion of the social determinants. But there is some speculations that the differences may be due to lower levels of education, individual preferences with job selections, much more interested in nonprofit types of work, and much more experiences of discrimination in healthcare settings and work opportunities, which may reduce the earning potential of these populations. The second area of what we consider social determinants of health is education. So we know that in general, cancer rates vary substantially based on education levels, with lower educational achievement associated with higher overall cancer mortality or death rates. Some of the reasons that the findings suggest that education is related to improved health literacy, improved decision-making, health decision-making, and a much higher rates of engagement in both health-promoting behaviors and having access to health-promoting social resources, such as normative norms in the communities that one resides in. When we look at sexual and gender minority and educational attainment, we have to sort of take a life course perspective. Education starts with the success of younger folks with educational attainment. Our strongest literature on educational attainment is associated with our LGBT youth that are consistently shown to have higher rates of poor academic achievement, high school dropouts, and what we're calling high school pushouts due to violence, discrimination, and other forms of victimization in the school setting. So we can anticipate from what we know from education among adults that our LGBT youth, as they mature and age into adulthood and older adulthood, will have a substantial increased risk for poor health outcomes, including potential cancer disparities due to educational factors. Next is the social environment. So physical and social environment in which a person lives or works has an influence on health outcomes, especially as we consider the literature on cancer and racial and ethnic minorities. What we see very strongly is that the social and environmental conditions produces higher levels of exposure to health risk and premature death, especially in racial and ethnic minority groups. The research in social context for sexual and gender minorities is a little bit stronger. We do see strong literature base that looks at levels of discrimination in various forms and how that relates to both physical health risk behaviors, mental health outcomes, and outcomes associated with chronic diseases. So there's a theoretical pathway that helps us to understand what some of the mechanisms are. And some of the research points to uses the minority stress model that points to the relationship between discriminatory behavior experiences and their direct influence on health risk behaviors as a means for coping. And then there's also a biological pathway showing that there are strong associations between chronic stress, inflammatory process, which leads to chronic diseases such as cancer. Okay. And the next area that I'll look at briefly is the healthcare system. So level of insurance coverage is an extremely strong predictor of cancer inequalities. We've seen from the Affordable Care Act, a lot higher percentage of Americans are now covered by health insurance, which is very positive. but there are still barriers within the healthcare system, including problems within the patient-provider relationship. Again, the literature is very clear, the descriptive literature is very clear on problems of sexual and gender minorities with experiencing discrimination in healthcare environment. Not only discrimination, but in provider ignorance around LGBT-specific risk factors and needs, provider homophobia, as well as poor access to culturally competent care. When we look at the neighborhood and the built environment, we look at issues such as access to healthy foods, the quality of housing, exposure to crime and violence, and overall pollution, exposure to pollution. And again, the literature this is a relatively new and emerging area as it relates to cancer, and it's really showing that the environmental factors such as pollution and crime have an impact on cancer disparities. The research here as it relates to sexual and gender minorities is just emerging. There's just been a handful of studies, but they're extremely interesting as it relates to the neighborhood context. Egan and colleagues found that there was an increase in health risk behaviors among gay men and MSM who had migrated from smaller towns into urban settings. We see a similar rates of high risk behaviors in what they refer to gay enclaves, or areas that in San Francisco, Chicago, and New York with high concentrations of gay males. And then there's one study that's conducted in Texas that showed higher rates of exposure to environmental pollutants in neighborhoods that had high densities of sexual minority men. Okay, so in terms of discussion, we see that their social determinants are important as we understand some of the drivers, the factors associated with cancer disparities, but the research among sexual and gender minorities as it relates to social determinants and the mechanisms the evidence isn't as there. So what we're recommending is an increased attention to conducting the standard types of questions that cancer researchers conduct in heterosexual populations. So looking at genetic factors, factors associated with healthcare, SES, diet, how that impacts sexual and gender minorities and their risk for cancer. So in conducting much more basic research inclusive of interventions, recruiting much higher proportions of sexual minorities in clinical trials, and increasing the proportion of scientists that are adequately trained and so I'm very pleased to see the doctoral student on this panel as well, representing our future. So increasing the diversity of researchers who are conducting cancer disparities research. Okay, so we have made a lot of progress. There's a lot more that can be done in terms of interventions and understanding the drivers of our disparities, but much more research is required as it relates to sexual and gender minorities. And hopefully that those of you on the panel as well as in the audience will be able to pick up some of this research as we move forward. If you're interested in more of this information, here's a reference from a study that I conducted with graduate students that provides all the citations for the presentation. So thank you so much for your participation.